I'm going to call this meeting to order. I'd welcome you all here. I think never have we been so ready so early. It's wonderful to have you all here. This is the May 8th meeting of the Washington Township Healthcare District Board of Directors. I'd invite you all to stand and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Dee, if you take the roll call for us.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Epen.
Present.
Director Wallace.
Present.
Thank you, Dee. As we've previously announced, the Board of Directors has appointed Jeannie Yee to fill the position that was vacated by Pat Danielson. We miss Pat, but we're very, very anxious and thrilled to have Jeannie join us. Tonight it will be our distinct pleasure to have Jeannie join us on the board. We're really looking forward to that. Tonight she will take the oath of office and then join us here on the board. So first I would like Nancy Farber to introduce Judge Nixon, who will be administering the oath of office to Jeannie.
It's my pleasure tonight to introduce Judge Thomas Nixon. He is the supervising judge for the Superior Court of California, County of Alameda, County's Family Law Division. Judge Nixon was appointed to the Superior Court in 2015 by Governor Jerry Brown and has served as a commissioner at the Alameda County Superior Court since 2002. He was an attorney in private practice from 1998 to 2002, a partner at Quaresma, Benya, Hall, Connaught, O'Hara, and Nixon from 1989 to 1998, and an associate at Quaresma, Benya, Hall, and Hahn from 1984 to 1989. Judge Nixon earned a Juris Doctor degree from Santa Clara University School of Law and a Bachelor of Science degree from San Jose State University.
Judge Nixon, if you come forward, and Jeannie, if you could come forward, we'll begin that this evening.
Are you ready to take the oath of office?
I believe so.
If you would be good enough to raise your right hand and please repeat after me. I, Jeannie Yee,
I, Jeannie,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
and that I will bear true faith
and that I will bear true faith
and allegiance
and allegiance
to the Constitution of the United
to the
States
Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely,
that I take this obligation freely,
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
upon which I am about to enter.
upon which I'm about to enter.
Congratulations, Jake.
Thank you, Dan.
You did a wonderful job.
Thank you.
Judge Nixon, we appreciate what you've done for us. It's very, very nice of you to come here and give us your time and your energy to do this.
It's my pleasure.
It's our
When I
pleasure.
was ill, it was this hospital that took care of me.
take just a very brief break, allow the Service League to congratulate their favorite person. And we'll reconvene in just a few minutes. After our brief break, we'll now convene the meeting and work further at our agenda this evening. The second item on the agenda is our education session. And Nancy, if you could introduce that for us, thank you.
We'll have two speakers this evening. Dr. Gabriel Herskew is a vascular and endovascular surgeon specializing in minimally invasive treatment of arterial and venous disease. Dr. Herskew grew up in Oakland, California, where his extended family still resides. He completed a degree in electrical engineering at the University of California, Davis, before attending medical school at the University of California, Irvine School of Medicine. He obtained his general surgery training at the UC Irvine Medical Center and then a 2-year vascular and endovascular surgery fellowship at the University of Southern California Medical Center in Los Angeles. Dr. Herskew's current practice includes general vascular surgery as well as minimally invasive arterial and venous treatments. He specializes in office-based treatments for varicose veins and other chronic vein disease. He has dedicated training in vascular ultrasound and is medical director of the Vascular Laboratory. He provides endovascular treatment of complex aortic pathology using the latest endovascular and hybrid techniques. Also speaking this evening is one of our employees, Linda Antes, RN, BS, MHA, CCRN. And she is an individual of whom I am especially proud. She's worked at Washington Hospital Healthcare System for the past 24 years. She began her career as a critical care nurse, taking on the most complex and difficult cases. Linda then transferred to the cardiac catheterization lab, where she became the primary charge nurse, overseeing an extremely busy and challenging department. She was responsible for developing protocols, procedures, and educational in-service for the new service lines within her department, including interventional radiology, electrophysiology, neurointerventional procedures, and radial artery access for angiography procedures. During this time, she was recognized for her clinical expertise and leadership skills and received a Nurse of the Year award from our medical staff. She has also served as the interim director of the Cardiovascular Services Department to oversee the daily operations of the cath lab, cardiac rehabilitation, and non-invasive cardiology for a period of 3 years. About 3.5 years ago, I asked Linda to oversee the development of a future neurovascular and cardiovascular hybrid OR of the future at Washington Hospital. In preparation for this project, she obtained an Executive Master's of Health Administration degree from the University of Southern California and transferred to the operating room. While in the OR, she has worked on many projects and held many roles, including neurovascular surgery coordinator, vascular hybrid OR coordinator, and relief charge nurse. She's attended many courses in leadership, including lean leadership development, American Organization of Nurse Executives leaderships courses, and she's been also a participant in our own local leadership, Fremont. She has tailored her career in preparation for the merging of operating rooms and cath labs, which lies in our immediate future. Very pleased to present both of these individuals to you tonight. They're a big part of our future.
All right, thank you, Ms. Farber, for the wonderful introduction, and thank you to the board of directors for having us here today. I'm excited to present this. This is something that I have a passion for, and that I'm lucky to be surrounded by other skilled providers who are cooperating and building this with me. My goal here is to talk about a little bit about the general practice of vascular surgery, but to focus more specifically on hybrid procedures and also specifically on a couple endovascular procedures that I believe are on your agenda today, endovascular aneurysm repair of the aorta. And so I'll give you a little more understanding, hopefully, of what that is and how we do that, and then a little glimpse at the future and what we can develop here at Washington Hospital. So vascular surgery is a very broad field. We treat the veins and arteries throughout the human body except for the brain and in the heart, so inside the skull and in the heart, which are managed by other fields, but all the rest are areas that we treat or have some involvement in. So vascular surgery has changed dramatically over the past few decades. It was purely open surgery until about 30 years ago. But we're privileged to be in a time when technology has advanced so much that it's having dramatic effects on medical care in a positive way. So the picture on the left here shows an open surgery with a patch angioplasty where an artery has been repaired with a patch made out of bovine pericardial tissue, so it's out of a cow's heart. And this was the only way of repairing arteries in the past. Currently, we're able to use technologies such as balloons. These balloons are inserted inside the artery and then inflated to treat narrowings of the artery. And stents, which are metal cages that are permanent parts of the artery, they're used to hold the artery open in certain circumstances. And these are made of special materials that are accepted into the human body and are able to maintain a shape that is desirable for repairing the blood vessels. So I want to talk a little bit about aortic aneurysms, which is one of the fields that has changed the most, one of the diseases for which treatments have changed the most in the past few decades. An aneurysm is a bulging of the artery. So a normal aorta will have a uniform character like this one. It's the main blood vessel from the heart that goes down to all the other parts of the body. And an aneurysmal aorta is one that's become enlarged for one reason or another. Most commonly, this is due to disease of the arteries, which leads to inflammation and weakening of the wall, and then the artery begins to enlarge. The pressure inside the vessel then continues to expand the artery, and these arteries are at risk of rupture if not treated. And sometimes they come to us already ruptured, in which case it's an emergency surgery that we do, but they're also treated electively to prevent rupture. And so for many years, these were treated only with open surgery. These can also occur in the chest, where it's called a thoracic aortic aneurysm. And I'll show you both of those treatments for this type of disease. So this is a picture of open repair of abdominal aortic aneurysm, in which a large incision is made down the front of the patient into the abdomen, an exploratory laparotomy basically. And the aorta is exposed and dissected out and then replaced with a tube graft. And this is usually made of a polyester material. And it's sewn in place and replaces that portion of the aorta. Then on the far right is a picture of the aortic sac sewn back over to close it up and keep it from contact with other structures in the abdomen. So this is a big surgery. This surgery had high morbidity and mortality associated with it, especially when it's done as an emergency procedure. And so this has changed dramatically in the past few decades with the evolution of technology. So this is the current way that most of these aneurysms are fixed, and that's with endovascular aneurysm repair. This is termed EVAR, EVAR, which is a treatment from the inside of the artery. So this is done often with percutaneous puncture through the skin and the groins, where a needle is inserted into the femoral artery and a wire is passed through. So tubes are inserted and a wire is passed through to access the aorta. And so the wire will pass all the way through from the leg all the way into the aorta. And all the repair is done over those wires, so from both sides, one from here, one from here. And a graft is placed through a thin tube on top of that wire into the aorta and then released. And that graft expands and matches the size of the aorta. So it's measured in such a way that it will form a seal above and a seal below inside the artery. And then when the blood goes through, it no longer enters the aneurysm sac. And so this is excluding the aneurysm from the arterial circulation. So now the blood will go through this tube and then into the normal artery below. This is one graft outside of the body that's shown here. This is one of the companies. And this is a three-dimensional reconstruction of a repaired aneurysm. And as you can see, there's no evidence of the aneurysm because the blood is filling now only the graft. And so the aneurysm is no longer receiving blood flow and is at very low risk of rupture after that repair is done. For aneurysms of the aorta in the chest, or thoracic aneurysms, a procedure called TEVAR, or thoracic endovascular aneurysm repair, is performed. Much the same concept. This is a wire inserted into the aorta, but this time in the chest, and a graft is placed to seal above and below and exclude the aneurysm. And this is another three-dimensional reconstruction of the aorta with showing severe disease of the aorta. So this is one typical patient that would receive this type of repair. This type of repair, when done open, is very high mortality and morbidity associated with it, particularly in the population that generally has this, which are older patients with other comorbidities. They can be in the hospital for a long period of time and have other morbidity associated with the operation. This is a typical thoracic endograft that is a covered stent. So this is a material called PTFE, which is an expanded polymer material. You may know it as Gore-Tex. That's the same material in this one. They also make them with the polyester material, which is also called Dacron. This area is the seal zone, and there's a special material over that to help better seal the device. And this is a material, the stent metal is a material called nitinol, which is a memory type of metal that finds has a shape that can be reproduced when it's expanded in the human bloodstream. So it has a memory shape alloy. This is a video of these procedures being performed. So this is the beating heart. We're in the chest, so this is a thoracic aneurysm, and you can see the aneurysm here. And so a wire is passed up into the arch of the aorta, and then over the wire, the stent is passed and positioned. This is all done under X-ray guidance or fluoroscopy. And then the stent is released and expands to meet the wall of the aorta. After that, a balloon is inserted to better oppose the stent with the aortic wall. So it'll show that we'll form a seal on the distal aspect of the stent and then also on the proximal aspect. And you can see the red blood cells going around the balloon. Hopefully there's a few more than that in the real situation. So sometimes this is also done with an open surgical component where these branches have to be rerouted and the stent placed even further proximally in the aortic arch. And so that shows the end result. In the abdomen, this is a typical look of an aneurysm in the abdomen where it's inserted through one groin. The graft is then released and expands out to meet the surrounding aorta. And in this one, because there's two legs of the graft, a second portion of the treatment is necessary, which is to put the other leg in through the other groin access. And so over a wire, the leg is advanced and it meets the existing main body of the device, and that sits in the abdomen that way. This type of procedure is often done percutaneous, as I said, so there's no incisions for many of these procedures. Patients are in the hospital. Usually for the abdominal aneurysm, they're in the hospital overnight only, and they can go home the next morning with basically full capability to perform activities of daily living. They only have to avoid heavy lifting, but can do virtually every other activity. The thoracic aneurysm patients stay a short time longer, but have a typical or similar course of treatment. So this is very different from the old way where the patient would be in the hospital weeks for recovery from this and would go home with 3 months of recovery still to do before they can return to all their normal activities. There are some new experimental type grafts that are coming onto the market soon where the branch vessels can be preserved without having to do open surgery. We're still doing this. When we have to do this, we're rerouting the branch that was coming off and covering the origin in the aorta. But these new devices have a lot of promise for even avoiding more open surgery and doing these endovascular. And so both of these are examples of that. This is the polyester version of the graft, and this is that other material, the Gore-Tex or PTFE. Here's a picture of a three-dimensional reconstruction of an aorta that had a dissection or a tear inside the wall and also has aneurysmal disease. Like I said, the aneurysm happens because of weakening of the wall, but it can be from this problem, which is caused directly by high blood pressure and also some genetic predisposition. But this is a typical type of case that we would treat. When it extends all the way over to the heart, it's a more complex problem that requires open and endovascular treatments to be used together for a hybrid repair. So this is a picture of a repaired aorta, at least the proximal portion. So the heart would be here, and the blood goes through here. And this is all graft that's been used to repair the aorta. So this was an open heart surgery in which a new aorta was placed here, and the arch vessels to the brain and to the arms are attached on top. This has been done in preparation for an endovascular component to be placed in this piece. So this is a tube going into the aneurysm that is able to accept the graft, the TEVAR graft, and complete the repair so that this whole area will be protected from rupture from aneurysm. And so the next picture shows that completed repair where the stent graft has been placed into the, what we call an elephant trunk, or this tube graft. And now the blood is going down through the graft only and into the distal aorta. But that huge aneurysm is now no longer filling with pressurized blood, and it's at low risk of rupture. And so this is an angiogram of that aorta after the reconstruction, showing that the blood now, and this is X-ray is showing this contrast dye that's put in here. The blood is now only going through the stent grafts and not into the large aneurysm sac. And in fact, the aneurysm sac is not even visible in this picture. So these interventions require both expertise, but also the technology to perform them. And we've been building more and more of this at Washington Hospital. We're doing more hybrid procedures than we ever have before. And they're successful, and we have a great team, and Ms. Antes has been a big part of building that, and Nancy Farber has helped us with supporting that effort. And so we want to see this continue into the future. We have great hopes for what we can do for our community, and we want to stay at the cutting edge of all these techniques. So I'll hand off to Ms. Antes.
Thank you. Hi, good evening, everyone. Let's see, how does this work? Let me just test this out. Okay, so I'm Linda. Thank you for your introduction. But I also wanted to say a special thank you to Ed Fayan. He has been very supportive and helpful in this process as well. So what you see up here is a picture of what we would love to see here at Washington Hospital. This is a beautiful hybrid OR. It's not what we have now, but it is state of the art, and hopefully we will get nothing less here. So what is a hybrid OR? It's a place where we do the procedures Dr. Hersky was talking about, but more specifically, it's really an operating room that combines the ability to do open procedures with a cath lab. Thank you. With a cath lab. And the cath lab allows us to put wires in through the groin or other access points, and combined, these procedures allow us to do just a huge variety of things. There's a lot of benefits for the patient, there's a lot of benefits for the hospital. So how do I go next? Thank you. Okay. So one of the first things we did here after talking with Nancy and her asking how can we get one of these here and how can we provide this service to our community was to develop a hybrid OR steering committee. This committee was put together about a year ago, and it is multidisciplinary. There are physicians from anesthesia, cardiothoracic, interventional cardiologists, thoracic surgeons and vascular surgeons, as well as Ed Fayan attends these. We have biomed there, we have IT, we have marketing, we have nurses and technicians as well as directors from multiple departments. These meetings have gone on without fail every month, and we have a very big attendance. A lot of discussions going on. We're talking about everything from future labs to how do we make decisions on what room to do them in, how do we schedule the procedures. It's just a lot of back and forth, and these meetings have become a very open forum for us to have these discussions, and it's one place for us to talk about how we want to proceed in the future. So some examples of vascular hybrid procedures are listed above. When we first started doing these, Dr. Herskew and Wortman and even Dr. Mahegan and Dr. Safaya, they were talking about EVARs and TEVARs. Bonus points for whoever remembers what that stands for. It is kind of important because there's a lot of acronyms out there, and coming in the future soon, we hope, is TAVRs. And people often get TAVR and TEVAR confused. So a TAVR is a transcatheter aortic valve replacement, which is a cardiac hybrid procedure. A TEVAR is the thoracic endovascular aortic repair, which is a vascular hybrid procedure. So we do those. We started this in August, the actual doing of procedures. We've done 69 of them so far. And they've gotten more complex and interesting as time has gone on. And we're constantly growing and learning from doing these. And our workflow has improved, our processes have improved, communication among staff and physicians, and a lot of education going on, but we've really come a long way. So these are just examples of the different types of surgeries that we've actually performed. And I'll just jump down to number 4 to give you an example. So we had a patient come in the middle of the night. It was an emergency. They brought him to the OR to do an exploratory laparotomy. So we had general surgeons for that. Then we did an infrarenal aortic stent graft, which is the cath lab procedure. We had Dr. Wortman, I believe Dr. Herskew was there. We had 2 anesthesiologists there. We had, I think there were probably 10 to 12 people in the room working on this patient. It went about 7 hours. We did left renal artery stent grafting, which was, again, the cardiac, the cath lab procedure, infrarenal aorta to SMA bypass with reverse saphenous vein graft, plus right great saphenous vein harvest, small bowel resection. You could see it was a lot of procedures were done in one place for that patient. They lived. And it is believed that we definitely saved their lives. They had been turned down from other hospitals to have this procedure done and basically told that there was nothing more they can do. So that being said, it is just amazing what we're able to do, and it's a testament to the skill level of our physicians. So one thing I wanted to say also about this, part of the reason why we hadn't done these procedures before is because we didn't have the proper equipment to do this. We recently purchased a C-arm with capabilities that has really opened the window for us to be able to do a vast number of procedures. It's actually, there's C-arms have really changed in recent years. And this one is a vascular package, and the imaging, I mean, I worked in the cath lab for years, and this imaging is as good as any I've seen. So that plus the purchase of a new table in the OR, which is unlike most OR tables. It looks like a cath lab table. It scans out 6 feet, it tips it, and you can do an x-ray on a patient from head to toe without any obstruction. So, and it has a free float technology, so the physicians are really able to move the patient closer to the x-ray machine, reduction of x-ray, and it's just an overall better procedure now. So more of the benefits that I was talking about. So patient safety. Patients have reduced radiation exposure because they're not having multiple procedures. We're doing it all in one room. We are constantly working on reducing radiation in the OR, and that is a work in progress. And as we do more procedures, we'll get better at it all the time. Also, you have reduced infection rates. The OR is a very sterile environment, and being able to do these types of procedures are really going to show very good outcomes. We're much more efficient. We don't have to transfer patients back and forth between departments. We have all the people there. We have all the equipment in one room. And you can do multiple procedures. We can do a hybrid procedure in this room, which is the combination. We can do surgeries in these rooms, or we can just do angiography, which we've actually done in the event that the cath lab has been overwhelmed or busy and they can't fit in a patient. So it has improved our efficiency. We have enhanced patient care. Patients are extremely satisfied with this. They don't have to have multiple procedures. That is a big stressor on people. It's a stress on their families. They do it all in one. The doctors are working together as a team. It's been a very positive thing for them. We hope to expand our service line in doing these types of procedures here. We're working on increasing our volume. We hope to attract new and highly trained, skilled physicians as well as staff. And I think it'll be really good for our hospital. Our future vision with our hybrid program is, especially for the vascular hybrid program, is to build an aortic center of excellence. We want to provide the highest level of care for vascular patients at our community hospital. We'd like to attract vascular aortic patients beyond our community, and we're working on outreach programs right now. Like to increase the volume and complexity of our cases, which I think we've shown we've already done. But it seems to be that they're getting more so, and we're getting better at them, and that we've had good outcomes. We also are planning in our meetings to the future hybrids in the Morris Hyman Critical Care Pavilion. We hope to have a neurovascular and a cardiovascular hybrid rooms for that building, and that is our plan, and we're all very excited about it. Are there any questions?
Thank you very, very much. It's exciting, exciting stuff.
It is.
I'm still, my mind is still back in the old mindset where an aortic aneurysm was almost a path to the next life. And it's wonderful to hear that you're able to do that closed and successfully.
Yeah, many of the patients, if they have the percutaneous procedure, have little or no postoperative pain. And so they wonder what all the big hubbub is about when I tell them about all the risks beforehand, and then we go and they don't even know where I poked them. So it's a big change, and it's revolutionized vascular surgery for sure.
Any other questions from the board?
Just one question. Can you comment about the utility of a hybrid OR in the treatment of trauma patients?
Yeah, so the trauma itself has evolved along with the other fields of surgery, and much of trauma is handled now with hybrid techniques. Aortic injury, I didn't talk about it today, but the aortic injury is treated really exclusively with these endografts. I mean, unless you can't, you do it with an endograph because it's such a less morbid operation. And so those are put in, as soon as that's identified on CT scan, that's put into the aorta and it seals the hole. And it really is the standard of care for trauma patients. So it's a necessity to have that capability. There's other injuries in the I can speak to the vascular components. Bleeding is generally handled with embolization. Certain areas of bleeding that are hard to reach surgically are handled with embolization, which requires fluoroscopy and that setting. Sometimes that can be combined with the open surgical treatments that are necessary in trauma patients. They often come in with multiple different types of injuries. And so having the flexibility to do those in the same setting where minutes matter is really huge. And so, and even simple arterial repairs, if there's a transection of an artery that needs to be repaired, rather than doing all the exposure, you can sometimes handle it with a hybrid endovascular technique that will immediately take care of the problem. And so having that close at hand is really the key in trauma. If you have to go out of your way to make all these things happen in different settings and different procedures, you lose time and you lose patience.
Thank you.
One
Great.
other thing, when we were looking at that beautiful hybrid OR, space is a big concern. It is really important to have at least 1,000 square feet on those. Part of the reason for that is maybe we can fit the equipment we have now, but because the future is expanding, you don't want to limit yourself to a room and you can't fit the new equipment in it. So keeping that in mind, especially as we're looking at things like trauma, we really need the space in these rooms to be adequate and to be able to move around safely in the room and to accommodate all the people and the other new equipment.
Great. Thank you very much. It's wonderful to have you both here. Wonderful to have that information.
Thank you.
All right, thank you.
And do you feel taller?
No, now I feel shorter.
The next item on our agenda is a consideration of the minutes for April 8, 9, 10, 15, 22, and 24 of April.
So moved.
We have a motion. Do we have a second? And a second. Dee, if you would call the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Yee.
I abstain.
Director Eapen.
Aye.
Director Wallace.
That motion passes. Jeannie Yee has abstained from that. She wasn't at any of those meetings. And so it's logical that she would abstain from approving those minutes. Are there any oral communications this evening? There are none. I have an item I'd like to speak to for just a few minutes. As it's important now to announce that on May 1st of this year, the board has received notice that our Chief Executive Officer, Nancy Farber, has elected to retire by October 28th of this year. Sadly, I've kind of known that this day would eventually come. Nancy has worked tirelessly for this district and its patients. You heard tonight just of one item. So much of what we are known as in a district is things Nancy has done in the district. Just to mention a few, the Morris Hyman Pavilion and the clinics and our patient first ethic. There is an almost endless list of very significant things that Nancy has accomplished as CEO in the last 25 years. At a later date, we will have a more appropriate setting and a time to acknowledge all that Nancy has done for the district. Suffice it to say that we, and I know I speak for the entire board, we're eternally grateful for the leadership you've provided and the devotion you've had to the hospital. This hospital system would not be the same were it not for your tireless efforts. And Nancy, it hardly seems enough to say thank you. And we appreciate all that you've done. And we will have a time when we can be in a different setting and talk and and properly honor this wonderful woman who's served the hospital, served the district, served the patients of the district in ways that I suspect may never be duplicated. You've done a tremendous job in the hospital, and we appreciate all you've done.
Thank you very much.
I also want to let everyone know that after receiving Nancy's notice, the board has met and decided to name Kimberly Hartz as Nancy's successor. Kimberly has been with the district for over 25 years. She has served in a variety of capacities, most recently as the Senior Associate Administrator for Ambulatory Services. Kimberly also has a long list of things she has accomplished, a long list of things that she's worked with. I want to just list a few. Her duties include financial and operational oversight of the following items: strategic management, contracting, community relations, government relations, off-site facilities, women's center, inpatient and outpatient ancillary services, the Washington Township Medical Foundation, and the Development Corporation, which includes Washington Outpatient Surgery Center, the Washington Outpatient Rehabilitation Center, Washington Billing, Washington on Wheels, Washington Urgent Care, Washington Sports Medicine, and Ohlone Health Center. Is that enough? Tremendously qualified in many, many areas. Kimberly has also played a vital role in the ongoing growth of our affiliation with UCSF. Succession planning is an essential tool for the success of a well-run organization. Washington Hospital has a very powerful and unique ethic and a culture that is tremendously important for our organization, but most importantly for the patients of the district. The board recognizes tremendous challenges in the future, and we feel that Kimberly has the ability to meet those challenges and maintain the district's culture of success, while at the same time remembering the patient-first ethic. Congratulations, Kimberly. We look forward to working with you. We look forward to working out the next months and doing the things that will be necessary to properly thank Nancy for all that she's done and properly get the ball rolling for the future. Thank you to both of you very, very much. Any other board members have anything they'd like to contribute to that tonight? Probably we'll have an opportunity to do that in the future. Nancy, thank you. We'll move now to written communication. That is Dr. Choi, our Chief of Staff.
Thank you. We'll be presenting the final credential action items. Initial appointments, we have two people. Shishandri, a pediatric physician, and Kia So, internal medicine hospital physician with sound. Next category that we have people with is the reappointments for 2 years. We have Dr. Jeannie An of nephrology, Dr. Stacy Berry, OBGYN, Dr. Vach Bezdikian, anesthesiology, PA George Bryan, surgery PA, Siban Calhoun, MD, OB, Dr. Kevin Gersten, otolaryngology, Dr. Thomas Harai, general surgery, Dr. Ashay Calais, orthopedics, physician assistant Nina Katibi, physician assistant Megan Nguyen, Dr. Anjali Sahai, hospitalist, OB, Dr. Yasser Sharif, anesthesiology, Dr. Benito Valencia, internal medicine, PA Christopher Wilkins, surgery, Dr. Jonathan Wong, pediatrics. Under reappointments for 1 year, we have Dr. Khalid Beg, Family Medicine, Dr. Yaga Kapila, GI, Dr. Ajit Sandhu, Pulmonary Medicine, and Dr. Gloria Yu, Pathology. Under transfer and staff category, we have Dr. Benjamin Deaton, going from provisional active to active, Dr. Ashay Kalei, going from ambulatory to courtesy, Dr. Lakshmi Manchaneni, going from provisional active to active, Dr. Andrew Phillips, from provisional active to active, and Dr. Christopher Voskopoulos, going from provisional active to active. Under proctoring completion of proctoring prior to eligibility for advancement in staff category, we have Dr. Solet Chantakote, and we have Dr. Michael Ross. Under completion of proctoring and advancement in staff category, we have Dr. Benjamin Deaton, Dr. Lakshmi Manchaneni, Dr. Andrew Phillips, Dr. Christopher Voskopoulos. Under extension of proctorship and provisional category 1 year, we have Dr. Anita Moongrady. New privilege requests include Dr. Jeannie An. And deleting privilege requests, we have Dr. Stacy Berry, Dr. Suban Kahun, Dr. Hanthi Tran, Dr. Christopher Voskopoulos, and PA Christopher Wilkins. Conflicts of interests were entered for Jeannie An, Kevin Gerston, and Ashay Kalei. Under resignations, we have Dr. Aditya Bhargava, Dr. Brian Macbeth, Dr. Ravindra Nalamurthy, and that's the end of my report. Thank you.
Thank you very much. I'll entertain a motion on that.
Mr. President, I move for approval of the credentialing action items as presented by Dr. Choi.
Second.
I have a motion and a second. Dee, if you'd take the roll.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Epen,
Aye.
Director Wallace.
Aye.
That motion passes. Thank you, Dee. We'll now have our Service League report from Ruth.
Good evening.
Welcome.
Thank you. So this evening, we're going to give our support to Jeannie Yee, as you can see by the number of volunteers that were here to support her as she was sworn in. Jeannie was a great asset to us in the Volunteer Services Department, and we're very appreciative and excited, simply excited to see her moving on to the district board. So congratulations, Jeannie. This month, we also had our masquerade sale at the beginning of the month, and we would like to say that we were able to use our new Counterpoint software and to be able to do real-time, on-time payroll deductions. Prior to this, we were doing a paper method where we were taking receipts and putting them in at the end of the day, but this time we were able to do it as they were checking out with the use of our new Counterpoint system, so we were very happy for that. And last but not least, we have another program that we're working on. We've been working on this 6 to 8 months, and it is a dog visitation therapy, and so we're really excited to have this coming on board. We're not quite there, but we're working. We have memorandums of understanding completed. We have certified trained dogs that have passed their certification, and we're going to be starting off with 3 teams. We don't know exactly our date to kick it off, but we have 3 teams ready. Can I announce the teams? So, the first team is Sydney Margolis and their dogs. Her dog is Apple. Our second team is Nancy Farber, and her dog is Calypso. And the third team is Russ Weinberg, and his dog is Ringo. So we're excited to get this going. The dogs are certified through TDI, Therapeutic Dog Internationals, and we have forms for the patients to sign, as well as volunteer services. So we've created documents for training on both sides. So we're excited to get this going. So in the near future, you will be seeing animals in our facility that are approved. Any questions?
Thank you, Ruth. Thank you. I became aware not long ago of the training.
Yes.
I was very impressed.
Yes.
It is not insignificant.
No, and it took a couple of times, so for some, so
Yeah.
we
Good.
can speak to that. So we're
Good.
glad to see that we've made great progress here.
Dr. Choi.
So for part of the medical staff report, I'm happy to announce that we have a grand total of 599 members now. Still not 600. Active members, we have 358, and ambulatory members, we have 103.
600 barrier seems
Can't do it.
Very, very secure.
Got 2 more months.
Thank you. Thank you for your report. Nancy, we now move to hospital calendar.
First, please.
Past health promotions and outreach events. On Thursday, April 11th, Dr. Victoria Liepart, gynecologist, presented Nutrition Myths. 32 people attended. On Wednesday, April 17th, Dr. Jenny Tran, obstetrician gynecologist, presented Early Detection and Prevention of Female Cancers. 13 people attended. On Saturday, April 20th, Washington Hospital's Green Team, the City of Fremont, and other local Tri-City organizations hosted the Go Green event. This free Earth Day Education Expo raised environmental and climate literacy awareness and shared eco-friendly ideas with people in our district. Attendees learned about recycling and how to save energy, in addition to learning about planet-friendly options available for everyday living. More than 1,000 people attended. On Sunday, April 28th, Washington Hospital sponsored a table at the Leaf Earth Day event in Niles. Members from the Green Team and Food and Nutrition Services provided information on healthy eating and sustainability. They gave away special prizes and 160 samples of healthy, locally sourced spinach salad. More than 400 people attended the event. On Thursday, May 2nd, Dr. Jelriza Mansouri, obstetrician gynecologist, presented Endometriosis, Causes, Symptoms, Diagnosis, and Treatment. 11 people attended. On Friday, May 3rd, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the Special Olympics track and field event at James Logan High School in Union City. 475 local athletes participated in this event. On Saturday, May 4th, Washington Hospital staff participated in the 4-mile March of Dimes walk for East Bay babies. Before the walk, staff provided maternal and newborn health education and offered interactive activities such as good hand hygiene practice and diaper changing practice. The event raised funds for research to prevent premature births, birth defects, and infant mortality. Washington Hospital was a silver sponsor, and the team raised an additional $7,103. More than 200 people visited the health information booth. On Tuesday, May 7th, Dr. Arun Shrivastava, gastroenterologist, presented Gastrointestinal Disorders. 57 people attended. Upcoming health promotions and community outreach events. On Thursday, May 9th, from 7 to 8:30 p.m., Washington Hospital will host Celebration of Life. This event will feature stories of survival and hope for cancer survivors and their families. The event is co-sponsored by Washington Hospital, HERS Breast Cancer Foundation, UCSF Washington Cancer Center, the American Cancer Society, Ambry Genetics, and the Tri-City Voice. On Thursday, May 16th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Liepart will present Bad to the Bone, Understanding Osteoporosis. On Tuesday, June 4th, from 6 to 8 p.m., Dr. Jason Chu, pulmonologist and medical director of Respiratory Care Services, will present Wildfire Smoke and Your Lungs. Do you need to worry? Wildfire smoke can be especially harmful to the elderly, pregnant women, children, and those with chronic heart and lung diseases. At this seminar, learn how to reduce the risk to exposure and how to protect your health. On Thursday, June 6th, from 7 to 8 p.m., as part of the Diabetes Matters series, Dr. Amir Dashka, podiatrist, will present Diabetes and Foot Health. At this seminar, learn the increased risks and symptoms of diabetic foot problems. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of April was Nutrition Health, featuring Kimberly Alvari, registered dietitian and director of Food and Clinical Nutrition Services, plus articles on portion control and exercise. The Washington Hospital Healthcare Foundation Report. The Washington Hospital Healthcare Foundation's 34th annual golf tournament took place on Thursday, May 2nd. More than 180 golfers enjoyed a beautiful day on the course, including refreshments, gaming holes, and a professional long drive golfer to help with their game. Following the tournament, more than 200 guests enjoyed dinner, an auction, and the awards ceremony. Eric Thomas, longtime broadcast journalist from ABC7, was the MC and auctioneer. Eric kept guests engaged in a fun-spirited competition, resulting in funds earned to support surgical services. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District board members attended the Fremont Leadership Prayer Breakfast and the Music at the Missions Masquerade Ball on April 12th. District board members also attended the Newark Chamber of Commerce's State of the City address, delivered by the Honorable Al Nagy, Mayor of Newark, on April 25th, the Citizens for Better Community Spring Celebration Gala on April 27th, and the HERS Breast Cancer Foundation's People with Purpose Gala on May 4th. Washington on Wheels, WOW, Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality health care services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of April, WOW served community members at the following locations: in Fremont, the Family Resource Center, Sunrise Village, TCV Food Bank and Thrift Store, and the Irvington Presbyterian Church. In Union City, the Ruggieri Senior Center, Union City Family Center, and Our Lady of Rosary Church. In Newark, the Viola Blythe Community Services Center, and the Salvation Army. These community partners provide social services to families in need and the homeless population. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of April was 91. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment section was April's most viewed webpage, with 34,602 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a news feed, which is the most common, a user's page timeline, or via direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of April, Washington Hospital's cable channel 78, InHealth, captured new programming including 2 health and wellness programs titled Metabolic Disorders and Early Detection and Prevention of Female Cancers, and a Diabetes Matters program on diabetes and kidneys. In addition, InHealth aired 3 health and wellness programs titled Colorectal Cancer, Food Pharmacy, Prescription for Colon Health, and Advanced Care Planning, 5 Wishes. InHealth also aired the April Board of Directors meeting. Awards and recognitions. The Morris Hyman Critical Care Pavilion was awarded LEED 2.2 certification for green building design for new construction. LEED, which stands for Leadership in Energy and Environmental Design, is a certification program that promotes sustainable design and construction and is based on accepted energy and environmental principles. Floor-to-ceiling windows in patient rooms and the atrium result in an abundance of natural light, which promotes patient healing as well as using fewer resources. The pavilion also reduces waste and many other negative environmental impacts by having water-efficient landscaping and increased ventilation filtration, plus use of recycled construction materials. LEED certification is a notable distinction for the Morris Hyman Critical Care Pavilion. Rinku Graywal, RN, is the latest recipient of the DAISY Award. DAISY is an acronym for Diseases Attacking the Immune System. This award was started in 1999 by the family of J. Patrick Barnes, who died of idiopathic thrombocytopenic purpura. His family established the award to honor Patrick and to thank nurses who, with their clinical skills, compassion, and extraordinary work, impact the lives of patients and their families. Rinku, a nurse on the telemetry unit, started at WHHS in 2010. Her peers nominated her for the Daisy Award because she provides extraordinary, compassionate care on the night shift. Rinku always goes the extra mile to ensure each patient gets the care they need, often going above and beyond her own responsibilities to help other nurses on the unit. Rinku supports the telemetry unit as a relief charge nurse and as co-chair of the unit-based council. She also played a huge role in the Morris Hyman Critical Care Pavilion transition by helping educate her peers. She is a team player, always looking to see how she can make a positive impact on a patient's or fellow nurse's night. Rinku is a special part of the Washington Hospital nursing staff. Washington Hospital and members of the medical staff, including Washington Township Medical Foundation physicians, were recipients of the Best of Fremont 2019 awards and honors. To determine the Best in Fremont awards, readers of the Bay Area News Group newspapers cast votes online. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
And now it's my pleasure to introduce you to our May Employee of the Month. His name is Kevin Angelo. And while some people might find the rumble of the machines in our laundry unit very aggravating, he thinks it's a very positive sound. The sound is good, he says. It lets you know everything is running well. He joined the Washington Hospital family 3 years ago when he applied as a per diem. His mother, Vitalina Angelo, works in environmental services, and she told him of the good opportunity for him. From the start, he impressed management with his positive attitude and willingness to learn multiple tasks. The Assistant Chief Systems Operations, Nick Legge, notes Kevin has excelled at all his tasks. Working delivery, he is the face of our department, interacting with all areas of the hospital. He transitioned to a full-time job and continues to excel. He is responsible for linen delivery to more than 20 locations. His manager, Brian Fell, has received many compliments about Kevin and the excellent work he does. Other areas of the hospital provide more direct patient care, but to Kevin, the role of laundry services is just as important. I feel like we have a behind-the-scenes part in patient care, a bed made with fresh linens, a blanket that smells good. These things help patient feel good and hopefully get better. Kevin adheres to the patient-first ethic in his work. He says the patient-first ethic is unambiguous. If you think about the patient's needs all the time, you'll always do the right thing. He lives in Hayward with his wife of less than a year, so he's newlywed, Marcella. They have 2 dogs, Callie, an English Bulldog, and Paloma, a white Chihuahua. When not cheering on the 49ers, Kevin and Marcella spend time outdoors hiking in Guerin Park, camping, or walking the girls.
We're ready for our quality report from Mary Boron.
Good evening. Tonight I'll be presenting our quality dashboard for quarter ending 3/19. So this will be January, February, and March. Starting off with our core measures, which of course is our standard set of interventions that we implement on patients who are at high risk for developing things such as a clot while they're in the hospital, known as venous thromboembolism. We've continued to have good success with the interventions we're doing. We have compliance that for this quarter was 94% outside of the ICU and 99% in the ICU. CMS has still not provided us with a benchmark to this, but I feel confident that we're in a range that is well above probably the national average for helping these patients prevent clot development while they're in the hospital. And our stroke core measure compliance also continues to be sustained at a good level of being able to make sure that these patients are getting the discharge medications when they need them 100% of the time in this case for the end of this quarter. And 100% of the patients who had a stroke or were at risk for having one were also at 100% compliance, making sure that they got the one-on-one education from the nurses and that was documented appropriately. Also, these patients were assessed for rehabilitation, and if they met the standard, they got the actual rehabilitation started while here in the hospital 98% of the time. So I'm confident that we're doing well in those areas of core measure compliance. Moving into infection prevention indicators, our central line associated bloodstream infection rate this quarter did show a little bit of an uptick. There wasn't a specific unit or type of pathogen that matched in these 3 cases of central line blood associated infections. But we still take each case individually. We look at it with a medical staff member, ID medical staff, Dr. Martin, nursing staff, all of us collectively together to look at, are these central lines meeting medical necessity requirements every day? Are we using the standard kits that we just implemented to make sure that people have all the equipment available at the bedside when they need it to change the dressings appropriately? So all those things are looked at on each one of these cases to make sure that we've done any sort of root cause analysis necessary. We take what we learn from that process and share it with nursing and medical staff to prevent them from developing again, and we're hoping to see a decline in that moving forward. For hospital-associated MRSA, again, this is an infection that's very difficult to treat with antibiotics, and in this particular measure, it's MRSA found in the blood. We really have been able to sustain success in here and have this found in the blood 0, again, as you can see, for the 6th quarter, so it's good. Same thing with our vancomycin-resistant enterococci infections, incredibly difficult to treat, even in resistant to vancomycin. We did not have any of those this quarter, so we're below the national benchmark on that. C. difficile, I think we've spent a lot of time discussing this and what we are continuing to do to prevent it. It's a multiple prong approach with working with EVS, antimicrobial stewardship, making sure that the patients get the right antibiotic at the right time and that we don't over necessarily prescribe them through having appropriate antimicrobial stewardship. In addition to that, we have really been looking at, are we testing the right patients? Are we looking at them from a whole perspective of are they at risk and do they meet risk for being a C. diff suspect patient? And that is reviewed daily with infection prevention, with the physician taking care of the patient and nursing. So when they've been doing this recently, we've probably done some more appropriate level of testing, which I think is attributed to us coming down. We're doing actually better than the national average here. We did have 9 cases. For a hospital of our size and type, the CDC, Centers for Disease Control, expected us to have about 11 infections. So this is good. We're continuing to see this go down. Moving on to colon surgery site infections, this is something that even on a federal and a state level we watch really closely. Washington Hospital has been able to sustain a rate of 0 for what is a high-risk procedure for developing a surgical site infection. So we're managing and doing these surgical bundles really well on this procedure. Same thing with abdominal hysterectomy. This is a lower volume of these, but we did have 1 infection, and so it will sort of tick you up to right at national average. That's basically what the CDC expected our hospital to have. But you can see, wouldn't call this by any means at all a trend. We've done very well there overall. Our nursing sensitive indicators, we're focusing on this quarter, is looking at patients who fell and then sustained an injury. Injury is it's a very high level of an injury. You can have an abrasion, you can have anything from an abrasion to, a skull fracture, and it's counted as an injury. We did have 1 fall. There are 10 total falls, but only 1 resulting in a minor elbow abrasion injury. So but even with that, we have to look at that and take it seriously and look and see what we need to do. So there's different things in moving in with the different building that we're looking at. Can we hear the alarms when we need to if a patient's trying to get up? Are we making sure to round on them continuously with certified nursing assistants to make sure that they can use the bathroom right before they go to bed? This is one of the things that we find commonly. People fall as they're trying to get up to use the restroom. So nursing has taken that really seriously and looked at it and making sure that they have the CNAs available when the patients need them at the time and have the support. Also looking at different types of alarms, even putting them on chairs so that when patients are sitting and trying to get up, we would be alerted if they're trying to get up on their own. So that's just a tad above the benchmark for California for CalNOC, but still, again, something we want to look at and take seriously. Our Joint Commission National Patient Safety Goals related to handoff communication continue to do really well. A Joint Commission expects you to, on a direct audit of observing a handoff at a shift or at a procedure, anything where you're changing a patient and from one area to the next, expect to see about 90% of the time we're holding steady here on those direct observation audits at about 100%. Same with patient identification, it's huge. Even though you can see that we're sustaining this very well, this is not a measure that you can really ever take your eye off of. Very high risk. This is where errors develop. If a patient's not ID'd correctly, it will follow down and can lead to serious consequences. So I'm glad we're sustaining it. We'll have to continue to watch it because it's huge in the area of patient safety. Same with procedure timeouts. We do this by direct observation. This takes place in all procedure areas, and we do direct observation and make sure that all elements of the procedure timeout are occurring. And in this case, for this quarter, we were able to find that 100% of the time. Hand hygiene. So we're, as you can see, roughly sitting about the same. For this quarter, 83.9%. Under the Joint Commission benchmark, which they are asking for about 90% compliance. And it's a very challenging thing, as you can imagine, making sure that people are washing their hands when they have all the opportunity and are supposed to. In fact, the national average rate we have on this blue line is anywhere from like 65 to 70%. That is the national average healthcare worker compliance rate. And that may come as a shock. You can read it anywhere from even 45% up to 70. So we looked at a lot of journals and various sources, CDC, World Health Organization, and this is about the average that we're finding. So we're not, compared to the national average, we're doing well. Still not good enough for us at 83.9%, and we do recognize that. There's a couple things that have a great deal of evidence that work to improve hand hygiene. One of which is sharing your feedback with the patient, with the nursing, all disciplines, respiratory therapy, anybody who's gone into the room and you've recognized hasn't washed their hands, physicians, all those. We try to give those healthcare workers feedback right on the spot. We call it just-in-time training to say that, we observed that you weren't washing your hands and kind of have a discussion and use it as a teachable moment. In addition to that, we share this on a unit base. It's posted. The staff's aware of it. So we are meeting the transparency, getting the awareness out there and getting the education out. Second part is making sure that people have the availability of sinks, soap, things when they need it. We did a whole new surge approach to that when we opened up the new building, hung up a bunch of new Perel, the main hospital still doing the same thing. We've also added a third element to this, and this is a hand hygiene campaign, because as simple as it sounds, but when you have visual aids and reminders out for healthcare workers or even patients or visitors in the hospital, it keeps it on the tip of their mind that this is an important issue. So what we've done is actually developed a couple of educational hand hygiene videos with the hospital staff that have come directly from them and they've created. We've done a couple videos, and you'll see we also have I think what is a great example. I've seen a lot of hand hygiene visual aid examples. This one in the back here, take a chance to look at it if you get an opportunity. It's fantastic. I was looking at it today. They've even got the the foam and the hand hygiene, the little clay bugs, and there's kind of these little rhymes written on them to help you remember what you're preventing the spread of. And a very easy, quick thing that a healthcare worker could look at and learn something and be reminded of in even less than a minute of spending time with that. So I'd like to share a couple of those examples with you and the video. I think Cherie's going to go ahead and show us where we're at with that. So this one is 6 West, I think.
6 West, 6 West. We do good hand washing, at least 20 seconds to drown the bugs, 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 bugs. Oh yeah, we've got it done, for we know the plan. Good hand hygiene, good hand washing, hands up. And we got both our hands all washed up to control the spread of bugs. Won't you do it too? 6 West remembers to wash, wash, wash the good hand. 6 West to right. Good hand hygiene is EVP. Yeah, 6 West to right. Good hand washing is best practice. So rub, rub to drown the bugs for 20 seconds. We're doing it right. Yeah, 6 West to right. Good hand washing is best practice. Hands up, and we got both our hands all washed up to control the spread of bugs. Won't you do it too? 6 West remembers to wash, wash, wash the good hand. 6 West to right. The good hand hygiene is EVP. Yeah, 6 West to right. The good hand washing is best practice. So rub, rub to drown the bugs for 20 seconds. We're doing it right. Yeah, 6 West to right. The good hand washing is best practice. Yeah, yeah, oh, when going in a room for a minute now, to every employee, it's what we're talking about. Keep those bugs under control. Wash it, baby, cause that's how we roll. Compliance is high, spread is low. 6 West knows best, don't you know? We say it and do it, infection rate drops. Wash your hands, don't never stop. Bada bing, bada boom. Gonna wash my hands when I step in the room. I'm a lifesaver, baby. Cause 6 West to right. The good hand hygiene is EVP. Yeah, 6 West to right. The good hand washing is best practice. So rub, rub to drown the bugs for 20 seconds. We're doing it right. Yeah, 6 West to right. The good hand washing is best practice. So rub, rub to drown the bugs for 20 seconds. Infection goodbye. If we do it right, the bugs and infection go out of sight. If we do it right, the bugs and infection go out of sight. Yeah.
Excellent. And we have another one on critical care.
Do the right thing, wash your hands now. 15 seconds is all you need. It's a culture of the unit. Wash your hands and be germ-free. All your patients will adore you if you keep them germ-free. 15 seconds is all you need. It's a culture of the unit. Wash your hands and be germ-free. All your patients will adore you if you keep them germ-free. Do the right thing, wash your hands now. 15 seconds is all you need. It's a culture of the unit. Wash your hands and be germ-free. All your patients will adore you if you keep them germ-free.
Excellent. They did a great job. I think that it's important to recognize that when you do a hand hygiene campaign like this and you involve the frontline staff and you get all the disciplines working together, I was reading in some journals actually in preparing for this presentation, they said do not ever underestimate the value of a hand hygiene campaign because you typically can't associate increased compliance right afterwards, right? Raising awareness, keeping it right on the front of everyone's mind. So I think they did a great job. Moving into our readmission rates, with pneumonia this last quarter, we did notice an increase. 28 patients came back out of 113, and which is above the CMS national benchmark, which is 16.7%. We were at 24.8%. So when looking at this uptick, we have the great opportunity of working with a analytics team that looks at this in detail. And there's a few things that we have recognized. These patients had complex illness. They were here at a season where we tend to notice this disease coming back and having readmits, and they stayed quite a while. Average length of stay for these patients was 7 to 9 days. A lot of them went to SNFs afterwards, home health agencies, and still actually came back. And so what we want to do is sort of go back and work with those skilled nursing facilities, working with the home health agencies to see what can we do more on our ends to prepare patients for these transfers into the community, into their home or SNFs again, and to prevent them from having to come back and be exposed to an acute care environment. One of the things that we have found in working with the skilled nursing facilities is that they deal with very complex situations in the non-acute care environment, right? And resources are different, and for a variety of reasons and needs, sometimes it comes to the point where they do have to call 911 and they have these patients come back and they're readmitted. And we want to look at what can we do to get in front of that and sort of help them to make sure that the transitional care planning is done in a manner that doesn't put the patient at high risk for coming back. That would be our focus for actually all of the readmissions, because you can see with the Medicare AMI, otherwise known as a heart attack, this has continued to be above the national benchmark, and we have 6 out of 20 patients who came back. This one is not so much related to cardiac things as it is that some of these patients also had some respiratory things going on along with it, because they tend to sometimes go hand in hand. So, but that is still much higher than we'd like to see it. It's at 30%. And heart failure readmissions, as you know, we have a clinical readmission reduction committee that I co-chair with Dr. Halimi, and we have, we got it down for a while last year, and then it sort of creeped up again. We are seeing seasonal increases in this. It's one of the things the analytics group has been trying to help us sort of do more prevention planning around that, very similar to the plan that I discussed with pneumonia. And those are all the indicators this quarter. Any questions?
Very much, Mary.
Thank you.
We'll now move on to our finance report from Chris Henry.
Okay, thank you, Dr. Stewart. Tonight we'll be looking at Washington Hospital's operational and financial results for March. Looking at our acute inpatient statistics, average daily census for March was higher than expected by 25.8 at 211.6. Admissions for the month were below budget by 79 at 1,123, but our patient days were 799 above the budget at 6,560, and of course that's going to result in a longer average length of stay for the month at, let me get that back up there, sorry about that, at 5.48 against a budget of 4.79. Outpatient observation equivalent days, incidentally, for the month were 79 above budget at 220 for March. Looking at utilization, case mix index for the month, a little bit lower than budget at 1.44. Deliveries for the month came in at 139. We had expected 152. So again, our delivery volume has been lower all year than we anticipated. Surgical cases came in above budget by 28 at 405. That includes our joint replacement cases that were 1 above budget at 141. Our neurosurgical cases that were 5 below budget at 26. Cardiac surgical cases for the month came in 3 above budget at 11. Nice to see that. And our cath lab procedures for the month were 24 below budget at 354. Outpatient visits for March were 350 above the budget at 8,114. And our emergency room visits landed at 4,840. We'd expected just a little under 5,000 for the month. Quick look at the cath lab activity for the month. Cardiac procedures in March came in at 41% of the activity, followed by our peripheral vascular procedures that were 36% of the volume. Non-vascular interventional radiology procedures came in at 21% of the volume, and neuro interventional radiology at 2%. Looking at FTEs, our productive FTEs for March came in 50.5 above the budget at 1,465.9. We had 128.6 non-productive FTEs in March. That was a little bit below budget. So we end up with total FTEs that were 35.9 above budget at 1,594.5. But when we go look at our FTEs per AOB, which is our productivity measurement, our full-time equivalents for adjusted occupied bed for March came in at 5.41. We had expected 6.36. So staff was stretched with the volume that was going on. Moving to the financials, first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation we use for our audited financials. Total patient revenue for the month came in $4.1 million above the budget at $202,608,000. Our deductions from revenue for our contractuals and bad debt came in above budget at 79.03%. We'd expected 78.79%. Actually, our contractuals were actually pretty good. The write-offs for Medicare, Medi-Cal, and our commercial payers came in at 76.35%. We'd expected 76.39% of gross revenue. It really was bad debt that drove this variance. And again, we've seen bad debt creeping up all year. So bad debt came in at almost 2.7% of gross revenue. We had been seeing much lower than that and expected 2.1%. So we ended up March with net operating revenue really close to budget at $42,945,000. Operating expenses for the month came in about $1.2 million above budget at $41,054,000. The big drivers there were salaries and wages with our higher FTEs. Also, of note, our salaries actually as a percentage were up higher than our FTEs. Because of the labor market, we generally expect to supplement some of our staff with registry in the winter months. But with the labor market here in the Bay Area, even those people are difficult to find. And so we're having to supplement with more overtime and double time than we normally would like to. So that ended up driving that number up a bit. Benefits were about $553,000 above the budget. That was driven by our pension adjustments that we've been taking this year. Also, our health and welfare was above budget. And then purchase services and pro fees offset those two unfavorable variances. They were below budget, almost $500,000. So we ended the month with operating income about $1.2 million below our expectations at $1,891,000. Non-operating income for the month came in $723,000 above budget at $641,000. That includes an unrealized gain on our investments of $713,000. So we end the month with a total bottom line from a GASB perspective at $2,532,000. We'd expected just a little over $3 million. Moving into our Financial Accounting Standards Board presentation. So this is a look at how Wall Street might adjust the numbers we just saw when they take a look at us. We remove, we do a few gymnastics here. We remove all of the income we receive to service our GO bonds, and we reclassify interest expense from non-operating to operating. So we end up with an operating bottom line from a FASB perspective of a little bit over $1 million against a budget of $2.2 million. Non-operating income lands pretty close to budget at $521,000. Total bottom line, just a little below $1.6 million. We'd expected $2,772,000. One more way to look at this. We look at our earnings before interest, taxes, depreciation, and amortization. In this look, we try to look at what the operation is producing before considering non-cash transactions such as depreciation and before we make interest payments on our debt. So EBITDA for the month from operations was $5.6 million. And our non-operating activities produced income before that interest expense of almost $2.7 million. So a total of almost $8.3 million of income generated to allow us to service that interest expense and future capital needs of the organization. So are there any questions on March's result?
Seeing none.
Okay.
Nancy, if you give the operations report.
Talk about the preliminary results for April. We had gross revenue of $176.1 million, below budget by $11.8 million, about a 6.3% negative variance. $8.8 million of our variance is due to deferred pricing adjustments. Inpatient gross revenue of $120.2 million was below budget by $20.3 million, but it was 4.2 ahead of April a year ago. Outpatient gross revenue of $55.9 million was above budget by $8.5 million and considerably higher than April a year ago, 12.9 ahead of last April. The shift from inpatient to outpatient is as we've characterized it in the past few months, largely related to joint replacement surgeries going outpatient at the behest of CMS. Major drivers of the revenue variance included inpatient days being below budget by 412, $5.6 million of this variance was due to deferred pricing adjustments. Emergency room visits were below budget by 503, driving emergency room revenue down by $900,000. And again, the deferred pricing adjustments featured significantly in the revenue variance, $3.2 million associated with that. Cath lab procedures were below budget by 28, but revenue came in above budget by 1.5 million due to the timing of posting of charges. Surgical services cases were above budget by 8. Our surgical services revenue came in above budget by 1.8 million. And the lower level of inpatient activity drove ancillary services revenue below budget by $3.5 million. Our key statistics include an average length of stay of 5.43 days, and that's above our budget of 4.94. Outpatient observation days were 22 above budget at 164 days. Average daily census of 165.2 came in below budget. We had planned for 178.9. Our admissions were 97 in number, below budget at 990. Major drivers of the admissions variance included inpatient surgeries coming in below budget by 69, and that is the joints being moved to the outpatient venue. Also, our deliveries were below budget by 25. Patient days of 4,956 were below budget by 412. Total surgical cases in April of 388 were above budget by 8. Inpatient surgeries were 69 below budget at 231. Outpatient surgeries were 77 above budget at 157. And again, it's the outpatient inpatient to outpatient shift in joint replacements driven by Medicare requirements. General surgical procedures were below budget by 7. Cardiac surgical procedures were below budget by 4. Neurosurgical procedures were above budget by 2. Joint replacement surgeries were above budget by 17. Cath lab procedures for April of 322 were 28 below budget, but 53 above April a year ago. Inpatient cath lab procedures were above budget by 25. Outpatient cath lab procedures were below budget by 53. Cardiac procedures in the cath lab came in below budget by 23. Peripheral vascular procedures were below budget by 19. Non-vascular interventional radiology procedures were above budget by 5. Neurointerventional radiology procedures were above budget by 9. Deliveries for April numbered 121, and they were below budget by 25. Non-emergency outpatient visits of 7,880 came in above budget by 795. That's an 11.2% positive variance. X-ray visits were above budget by 234. Cardiac rehab visits were above budget by 142. Infusion visits were above budget by 127. Lab visits were above budget by 115. And prenatal diagnostic center visits were above budget by 76. It's a busy clinic, growing by leaps and bounds. Our emergency department visits of 4,337 were below budget by 503, but above the same period last year by 276 visits. Productive FTEs were below budget by 2.1. Non-productive FTEs were also below budget by 16.4. So our total FTEs of 1,538.1 were below budget by 18.5. Total productive FTEs per adjusted occupied bed of 5.65 were below the budget of 5.72. Total FTEs per adjusted occupied bed of 6.35 came in below the budget of 6.5. Other operational statistics of interest, our outpatient surgery center had 498 cases in April, and these were 30 in number above the budget. Clinic visits of 3,693 were below budget by 493 for the month. Preliminary payer mix information for the month of April was not favorable. Government-sponsored patient revenue made up 75.2% of total gross revenue. That's not a good number for us. We had budgeted 71.9%, and it is amazing how much difference those few percentage points will make. HMO revenue was 2.4% of gross revenue, which came in below our budget. PPO revenue was 21.2% of gross revenue, which was below the budget of 22.9%. And again, that makes a huge difference. Private pay revenue was 1.2% of gross revenue, which was lower than the budget. Days cash on hand for April ended at 143 days, down 5 days from last month. Part of this is related to a $1.4 million IGT payment and the annual payment of 403B employer match money of $2 million that was made in April. Currently, there are also $10.1 million in supplemental funding outstanding from the state, and these payments have been delayed since February, and this amounts to 8.2 days of cash that we do not enjoy right now. That would have brought our days cash on hand up to 151 days. So the state's hanging on to it for some reason. Possibly they want float benefit, but we don't have that money yet, and it was due here in February. Days of gross revenue and accounts receivable were 51, which is a very good number. Our billing department is doing quite well. There were $272,889 in charity care applications pending or approved for the month of April. And now I want to give my report on homeless patient activity pursuant to the Senate Bill 1152. Total homeless patient encounters for April was 182. 29 of these patients had more than one encounter. The estimated incremental cost of 1152 for the month of April is $80,000. Estimated total unreimbursed cost of homeless care for the month of April is $378,000. And the estimated total of unreimbursed cost of the homeless care calendar year to date in April is $2.1 million. So this is the running total on 1152. And it's my intention to bring it to the attention of the public and the board every month. It is a completely unfunded mandate and unanticipated and unbudgeted expense.
Thank you very much. Nancy and Chris, thank you. We're at a point where we need to do our motions for action items. Those fall to Director Wallace tonight. Item A.
Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors authorize the Chief Executive Officer to execute the appropriate documents to proceed with the purchase of 2 Verathon gyroscopes in an amount not to exceed $31,890.
Second.
We have a motion and a second. Nancy, if you'd like to explain that a little bit.
Gyroscopes sound so good. From the patient's standpoint, I think they're happy we have them. This equipment is used to provide reliable and consistent views during difficult endotracheal intubation. The capital budget included replacing the units in the operating room and OB. The current equipment was purchased in 2008. It has no remaining book value. We're getting a $1,000 discount for each unit that we trade in. And we're pretty much in line with the MD Byline recommended purchase price, and it's a budgeted item. I would request that the board approve it. It's used daily in patient care.
Okay. D, if you would take the roll, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Eapen.
Aye.
Director Wallace.
Aye.
Item B.
Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors appoint Stephen Chan, DDS, to fill the vacant position on the Washington Township Hospital Development Corporation Board of Directors for the remainder of the 2019 calendar year.
Second.
A motion and a second. Nancy, do you have any comment on that?
I think the board members who might not have known Steve got a chance to meet him last month. Many of us have known him for quite a while. He's a stalwart in our medical community. He's been here for a long, long time and definitely has ties to the hospital and cares very much about Washington Township Healthcare District, and very pleased that he was willing to consider service on the DEVCO board.
And I'd second that. I find Steve to be a very, very fine man. He's done a very, very good job in the community and in his practice as a dentist. I appreciate all he's done. Any other comments on that? Dee, if you'd take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Yee. Director Epen.
Aye.
Director Wallace.
Aye.
That motion passes. We'll move to item C.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the contrast media usage, GFR, and hydration protocol for the use in the medical imaging department as presented by the Medical Executive Committee.
Second.
We have a motion and a second. Dr. Choi, would you like to comment on that?
Sure. It's basically a protocol to help preserve renal function in patients with compromised renal function by adequately managing their hydration.
Then, any questions on that from the board? We'll take the vote. Dee?
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Yee. Director Epen. Director Wallace.
Aye. We'll move to item D.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the privileges for endovascular abdominal aortic aneurysm stent graft placement, EVAR, and thoracic endovascular aortic aneurysm stent graft placement, TEVAR, as presented by the Medical Executive Committee.
Second.
A motion and a second. I'd like to congratulate Director Wallace on that pronunciation. He did well. Nancy, if you, I think we've had a presentation on that.
Yeah, you had a presentation on it.
I think we're all very, very familiar with that. I'm
But
glad.
this is also part of the medical staff cleaning up any things that need to be brought up to date within their manuals and in their protocols. We, believe it or not, are going to have a Joint Commission survey, not this summer, but next summer. It seems like we just did it.
Definitely does.
And, you know, the medical staff has really done a yeoman's job of addressing their bylaws, and this is in a similar vein, getting these things all tidied up, and Joint Commission will be here before we know it.
Good. Dee, if you'd like to take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Yee. Director Epen.
Aye.
Director Wallace.
Aye.
That motion passes. Thank you very much. That brings us to the end of our agenda for our open meeting this evening. We'll adjourn now to a closed session. Thank you all. We'll now reconvene to an open session and announce that no reportable action was taken during the closed session. There being no further business this evening, this meeting is adjourned.